Yes.
Now it's okay, but why I don't get the recording button? Yeah,
But we got the message that it is being live streamed.
yeah, now it's getting recorded.
Good afternoon, everyone. I welcome you all on behalf of Palghar Academy of Pediatrics. Today's Wednesday weekly webinar is in collaboration with Maharashtra State IP branch. And I welcome Dr. Jay Bhandarkar, who is a state convener of Maharashtra IP branch. I welcome all the delegates whom I see from various other branches also. So a warm good afternoon to everyone. I would like to highlight a few brief description about what we did last week. Last week, we celebrated Down syndrome. In this, we had a CME in which Dr. Shruti Bajaj was our genetist who had a small talk on how to do the follow-up of a Down syndrome child. Because all we know till now is about Down syndrome. We don't know after the child has been diagnosed what to do further. So she highlighted us what are the points to be looked on, what are the investigations to be done. Similarly, we had a Down syndrome get-together of the kids who were examined, and they were done free 2D echo, free CBC and TSH were done. While doing 2D echo, one of them had a problem, needed surgery, so was referred and guided accordingly. PEHL is a support group which was started by one of our branch member, Dr. Shruti Bajaj, way back 4 years back. At that time, we had a get-together and we had checked 40 kids of Down syndrome. And now that has come down a little bit to around, say, 10 to 20, but still we are doing a good job in evaluating the Down syndrome kids. And PEHL is a support group for all the Down syndrome kids where they come, enjoy, and then discuss their things and all. So we have a get-together of PEHL with the IEP on 20th of March. So all those who have, who know their patients with Downs can enroll in that. So now coming with today's webinar, World Oral Health Day is celebrated on 20th of March. Why the need for a World Oral Health Day? Because of the changing lifestyle that we are facing nowadays. The need of the webinar is because of the increasing problems which are developing in the kids. The kids are now more prone to chocolates and more of the aerated drinks. And they don't know how to keep the oral hygiene. Even we as pediatricians have to face such problems because of the Google parents. Like what is the type of toothpaste? What is the type of brush? They keep on hammering us. So let us know what type of toothpaste and toothbrush in the exact way of brushing our kids' teeth and even ours by our very expert speaker today, Dr. Meenakshi Clare, who is a practicing pediatric dentistry in Mumbai. And to moderate the session, we have Dr. Anjali Gokarna Madam, who is a practicing pediatrician in Vasai. So I welcome Dr. Anjali Madam to moderate the session.
Thank you so much, Vaibhavi, for a very quick update on last week's events. And I want to say that when we examined this time, we had included only parents from Vasai Virar area because it is difficult for them to travel. And that is why there were only 10 families and each of them had a dental problem. So that is the importance of having Down syndrome and an oral health day that's coming together. And I think you will touch upon, special needs children with dental problems. So Vaibhavi has already said why we are doing oral health day with, talking about pediatric dentistry. So let me screen share to tell you about our wonderful speaker. So all of us always have had issues with pediatric dentistry because, like Vaibhavi said, which toothpaste, which toothbrush, how much to use, and how to use, how to brush. So I remember many years ago, it was Meenakshi who had said she looked even younger than this, and my kids were absolutely awed by her, and they still are. And when I told them last time when I heard her that Meenakshi is going to, oh, our dentist, you mean? So they're still possessive about her. And at that time, I remembered that Meenakshi had said how to brush. And that was something even I didn't know. And we always brush like this. And Meenakshi had so carefully said, this is how you have to do it. And she's, of course, going to touch upon this in the talk when she has it. And Meenakshi Kher has been in practice with a master's degree in pediatric and preventive dentistry from Mumbai, University of Mumbai. And she is one of the leading pediatric dentists. After you've heard her, you will definitely agree and you will know why. She has established this happy tooth clinic for kids. And this concept of having a separate tooth clinic was so amazing. When we went to her clinic so many years back, she had chairs which were shaped like teeth. And our kids were so excited, they went on sitting on each seat. So this happy tooth clinic is something which is very appealing, very exciting. And she's doing exclusive pediatric dentistry for kids up to 18 years of age. She's committed to this, and she's also committed to teaching. So once we've heard her, you will agree that it takes something else to be a good dentist, and it takes even more to be a good teacher. So and someone who can share something so well. So she has been involved in continuing dental education, and she's authored a book. I'm always in awe of people who write books because that's a task, it's a commitment. And she's written about contemporary treatment techniques in pediatric dentistry. And I have invited many pediatric dentists today, and I hope everybody gets to read this book. And I'm sure you're going to highlight a lot about what we don't know about pediatric dentistry, Meenakshi Kher, and that's going to be quite a bit. So over to you, Meenakshi.
Thank you. Thank you so much, Dr. Gokarn. It's a pleasure to be here and honor to be speaking with all of you. In the past, I've always had, this wish to reach out to more pediatricians, because honestly, you are the people who see children first, and we get to see them only once it's a mess in the mouth, because the concept of prevention and anticipatory guidance still doesn't exist in our country. I've been practicing for 27 years now, but very little has changed. So it's just wonderful to see the interest that pediatricians are showing in the subject, because it all starts from you, and we just come later. So like you say, brush twice a day. Brushing up on pediatric dentistry, I hope, happens once in a couple of years for all of you. That'll be like really wonderful. So without much ado, I'll quickly go on to sharing the screen. Dr. Gokarn and I met just a month back when I spoke to this really large gathering of pediatricians. Close to, I think, 90 of them were there for that 2-hour session. So I'm hoping to surprise you with a lot more about pediatric dentistry than only oral hygiene, though it all begins with oral hygiene. And again, it all begins from your office, because you're the one who first inculcates it in that child. So of course, I will discuss all of those things. So what I actually planned today is, the last time we had this meeting, for about 15 days, pediatricians were asked what were the questions they would like me to, topics they'd like me to highlight, and what they would like me to discuss. And they had this very long list of questions. And I actually made this presentation keeping all their questions in mind. And because that kind of covered the whole gamut of what I want to share with you today, I have, maintained the same thing. And of course, I can address anything that I have left out. I can address after we are done with this session. So I will just share my screen. Can you see me? Yeah, it's all clear. Great.
Yes.
Super. So, yeah. So let's brush up on pediatric dentistry. Like Dr. Gokarna said, I still practice in Andheri West, close to Lokhandwala. We had the wonderful opportunity of moving into a new space now. I was there for a very long time, and we moved into this really lovely space, and children really love it, especially after 2 years of being locked up at home. It feels so good to see these children have such a wonderful time at the practice. It's really heartwarming to see them enjoy themselves. The whole place is child friendly, like Dr. Gokarna said, and that makes children comfortable because dentistry is always associated with fear, with discomfort, and the parent gets the child to the practice already fearful. So, when you see a warm, friendly atmosphere, that already makes the job easier. And, our jobs are very difficult, you'll appreciate, because nothing is voluntary. Everything, is voluntary. Unlike maybe a vaccination that you somehow manage to push into that child, even if the child is resistant. In dentistry, nothing can happen with force. The child has to voluntarily cooperate. So, the atmosphere and all that really makes a difference. Though we treat children from 0 to 18, and honestly, I need to treat individuals who are older than 18, especially when they have special needs, or when they have, whether it's intellectual disabilities, cognitive disabilities, developmental disabilities. I need to see them because there are very, very few dentists out there who take care of these individuals. So we see all of them above 18, but other than that, it's 0 to 18, but with a special focus on toddlers, on special needs, because these are age groups that are very, very difficult even for general dentists to treat. That's my team. I'm nothing without them. And in 2010, I started Pedo Pathshala. This was a continuing dental education program that taught clinical pediatric dentistry to dentists and to pediatric dentists across the country. I've been very blessed that it was so successful. I've had international delegates constantly attend the course, and it's been wonderful. The more you teach, the more you learn, honestly. So with every time I teach, I realize how much more I learn. So it's been learning for me, and of course, spreading knowledge. In 2019, I authored this book. I was very fortunate to have Springer International Publications as my publisher. And it's a atlas of clinical techniques that handholds the clinician through various procedures. And I'll share with you my 27-year journey as a pediatric dentist, but more importantly, with focus on what is relevant to you. I'm not going to get into dental techniques and things like that. If you are interested, we could do that another day. But mainly, I want to share with you where you come in, because like I already said, there's just so much that you could do and you could catch early on, so that children, aren't are saved a lot of the dental issues later. So I'm going by the questions that I was asked. A lot of this is not new to you. Natal and neonatal teeth are not new to you. You see them all the time. You know that natal teeth are present at birth. They are far more common, and on a ratio of 3:1 as compared to neonatal teeth that will appear in the first month of life. These teeth may vary in size and shape and color. They may look smaller than normal teeth. They may appear, their shape may be very different. They could be conical. They may be a little yellowish. They may be a little opaque in color. All that is really irrelevant. What is truly relevant is when it becomes mobile, because the attachment is very, very poor to the alveolar ridge, or when it starts hurting the mother, when the child is breastfeeding, or when it hurts the child and causes an ulcer under the tongue. So when there is Riga-Fede disease, of course, we need to extract right away. We also extract when there is difficulty in breastfeeding because of the ulcer, or because of pain to the mother when she is feeding. And of course, if you find that the tooth is too mobile, then we extract, because the last thing we want is the risk of swallowing, but even more important, the risk of aspiration. So we just apply a topical gel and we extract. Of course, we have to ensure, just give me a second, I'll get this bar out of the way. We have to ensure that, we just confirm that the child has had their vitamin K, but nowadays, that's not an issue. They've always had it right in the beginning as soon as they are born. On this topic, I was requested to touch upon neonatal and natal teeth, but I just added this bit about congenital insensitivity to pain. This is really rare, but because I guess we are pediatric dentists, I have seen a couple of these children, and it's honestly really heartbreaking and horrifying to see these children, because one of the first times you realize that there's congenital insensitivity to pain is when those two lower primary or milk incisors erupt in the mouth. The moment they erupt is the first time the infant feels contact of soft tissue to hard tissue. And they're suddenly feeling this hard tissue against their tongue, but there's complete insensitivity to pain. So they literally chew off their tongue like chewing gum, and kids will lose the anterior tip of the tongue within a couple of days. It is that traumatic. So it's an absolute emergency, and then we need to extract these incisors and then keep extracting. Most often nothing else works for these children, but I thought I'll just touch upon congenital insensitivity to pain, because very often we are the first ones who seem to see them. There were a lot of questions on teething, because again, when there's teething, nobody calls up a pediatric dentist. Unless they've had an older child who's seen a pediatric dentist, nobody's going to call us up. They're all going to bug you about the teething. So I'll just touch upon it. There's no new science really. And I guess you pretty much know everything about it, but I'll just quickly go through, because it causes so much anxiety in parents. Often it is blamed for all kinds of illnesses, right from fever to diarrhea to rashes. But what happens is that the timing of teething often coincides with the same time period in an infant's life when passive immunity due to maternal antibodies is waning, and there's exposure to a wide variety of childhood illnesses. They are putting things in their mouth. They are mouthing all the time. Oftentimes things are not clean, and that is why they land up with the diarrhea, with the fever. So what do we do with teething when the parent asks you? But first of all, the pattern of eruption, that is another thing I was asked about. So the first milk teeth, they erupt at an average of 7 to 9 months of age. They will continue to erupt right up to 36 months of age, 30 to 36 months, but these are only averages. It is perfectly normal for an infant to not get any teeth on their first birthday, to be toothless on their first birthday, and to get that first baby tooth well into when they are 14 months, 16 months, rarely even 2 years is absolutely fine. Very, very rarely do you have a situation of ectodermal dysplasia or something. Most often, it's just the pattern of teething is late. And honestly, late teething is the best form of prevention. There can't be any better prevention than to have those teeth nice and secure inside the alveolar ridge and gum pads and not in the mouth. So late teething is excellent. So what was the other questions I had were, delayed and premature eruption of teeth. So if it's premature, like if the first baby tooth, the child cuts at say 3 to 4 months of age, that is truly very early. And the mother is breastfeeding, hopefully, and it's really hard to maintain oral hygiene at that stage. And someone needs to be telling them how to take care, because these are the children who appear by 1 year of age, come to us with severe early childhood caries. So early premature eruption or eruption at 3, 4, 5, 6 months is really early. And these are the parents and children, these are the dyads who really we need to be cautious and take care and advise about oral hygiene. Delayed exfoliation was the other question that pretty much follows the same pattern as delayed eruption. If there's delayed eruption, there'll be delayed exfoliation, and there's simply no problem with it, provided of course there's no pathology, meaning it is not a treated baby tooth, which was an infected baby tooth where perhaps there was root canal treatment done, things like that. Then the pathology could contribute to the delayed exfoliation, but otherwise delayed exfoliation is absolutely good. So what are the symptoms of teething? That's my son, of course, and he'll keep popping up for you. He's not here, so I just feel good looking at his baby pictures, whatever little I have of his. So because we didn't have cell phones then, so we didn't keep shooting. The most common symptoms of teething, of course, is soreness of the gums around the erupting tooth. The child may be irritable, the child will drool, the child will mouth everything. They may want to put everything in their mouth and they may want to chew. So these are the typical symptoms. And of course, you know all of this. And the remedies honestly haven't changed. A gentle massage with a clean finger. They call it cuddle therapy now. So, but what it really means is hold the baby a lot. The baby's not feeling very good. So hold the baby a lot. Your baby is irritable. Gently rub the gum pads with a soft cloth that is dipped in ice water or with an ice cube. So basically anything chilled will be very, very soothing for the irritated gums. The other thing you can do is chilled teethers. What are the best teethers? Natural teethers, like a chilled slice of apple, chilled slice of cucumber, of carrots, are great natural teethers. Of course, supervision is required. Someone needs to be sitting there to make sure pieces don't break off and the child doesn't choke. That goes without saying. Even chilled bananas, which are far safer, but basically nice and chill. It'll be very soothing, and you're teaching the child to self-feed. You're teaching the child to pick up a finger food and start eating, and you're teaching the child not to start off with something like biscuits, which are just maida and sugar, which unfortunately are the most common finger foods that parents first pick up, and which are such disasters for the teeth and which are so full of free sugar. But I'll come to that later. And then there are commercially available, good quality silicone teethers for those who have access to them, those who can afford them, and those who can get them. Those are a great alternative. And of course, if the baby is distressed, despite these simple remedies, if the child is ill, the child has fever, then we would advise they see their pediatrician to see if the child has some infection and to attend to it. Another thing I was asked was about medication during teething, but honestly, just a paracetamol or an ibuprofen will be all that is recommended in the dosage that the baby usually has for fever. Topical anesthetics should be avoided, especially if they have benzocaine, because that could increase the risk of methemoglobinemia. So we don't want to ever use benzocaine in infants. If at all, it has to be a lignocaine topical anesthetic, and those are not available over the counter as far as I know, at least in India. The other question I was asked was about homeopathy. So I don't have concrete evidence for it, but of course it's used really widely and parents say it really helps, and chamomilla is supposed to be very, very helpful. Now comes to the point, to the subject of oral hygiene. And this is one area where there is utter confusion because of our poor understanding of what we are trying to do when we are actually cleaning teeth, and of how much these two things, that is good oral hygiene and a control over free sugars in our diet, can completely avoid the need for any dental caries whatsoever. Dental caries is completely preventable, and I'll go to that. Where oral hygiene is concerned, it really helps to start early. And when I say early, I mean even before the first two teeth erupt in the mouth. Since there are no teeth, you will wonder, what cleaning has to happen? But since there are no teeth in the mouth yet, there is obviously no plaque on the teeth that you have to remove, because when you're brushing, what you're doing is you are aiming to remove plaque, which is a very, very sticky biofilm that keeps forming on the teeth 24/7. So when you're brushing, you're trying to remove plaque. But I'm saying here that we start oral hygiene even before the first teeth come out. Why is that? Because there are many, many advantages to an early start. What are the pre-brushing aids we recommend? A soft silicone finger brush, a soft baby brush, or just a plain, clean, soft cloth. All of these will work very, very well as pre-brushing aids. Why? What are the advantages? First, we all know that children thrive on a routine. They feel very, very comfortable when they know what to expect next, right? So starting early helps make brushing twice a day a part of routine, because honestly, in India, both you and I know that culturally, brushing twice a day, no matter what, is simply not there in our culture. Whereas our diet, like the doctor in the beginning pointed out, is getting more and more refined and more full of refined carbohydrates. So starting early helps brushing twice a day become a part of the routine for the parent, the routine for the child. Because see, for bathing, it's a routine. The malish bai will come or the mother will bathe the baby. Bath is very, very important to us as Indians. But where oral hygiene is concerned, our whole attitude to it, our knowledge of it is extremely poor. So this sets the tone. And it is best to incorporate this activity along with the routine, just like you would incorporate a bath, a bedtime song, a lori, or a bedtime story, something like that. So you include this as a part of the routine. So just with a soft cloth, wipe the gum pads, and that's all that needs to be done. So the baby's on the lap, and you're just wiping the gum pads with the soft cloth. I'll play that for you once more. So it familiarizes the baby with the foreign sensation in the mouth. The mouth is a very, very private part for the baby. And we are now suddenly invading the mouth, right? So it's lovely for the child to get used to it. So it familiarizes the baby with that foreign sensation. It familiarizes the parent to have the baby lying down on the lap, the parent bending down, looking at the baby, flipping the upper lip up the way this mother is doing here, and then using the pre-brushing aid to wipe the mouth with a soft cloth. This should start by 6 months because you're hopefully exclusively breastfeeding until 6 months of age. And now you're going to start with the top feeds, with the solids rather. And this is a great time to start, whether or not the teeth come out, to start with this pre-brushing tool. Because if the teeth have started coming out, then this will not work. Because once the teeth come out, you need to start using a toothbrush. So what toothbrush will you use? 0 to 2 years of age, you could use a soft baby brush. And so I'm just going to tell you the ones that are easily available at the chemist. So Colgate has the 0 to 2 toothbrush, which is great when the first teeth come out. But once your child is around 2.5 years of age, you should move over to a junior brush. So Oral-B, excuse me, calls it 3+, and Colgate calls it 5+. Don't look at 3+ and 5+. Straight away at 2 years of age, move over to a junior brush, that is 3+ or 5+. And at around 7 to 8 years of age, once the permanent teeth start to erupt, start using an adult brush straight away. Only use a smaller head. You have a huge variety of adult brushes. Try and look for a smaller head. So when the child cuts their first baby tooth, start using the 0 to 2 brush. And then I think we just did this, past 2 years of age, use the junior brush and an adult brush later. Motorized brushes are very, very useful, but use the chargeable ones, not the ones that have the battery. Use the chargeable branch, especially because they are more efficient. And now they are very, very easily available online on Amazon. They are very, very easily available at the chemist. And they are extremely efficient, especially in children with special healthcare needs. If the child can tolerate the vibration of a motorized brush, it really becomes very convenient, even for the parent, to slowly start making that child more, or that adult more independent. Now, what toothpaste will you use? The International Academy of Pediatric Dentistry, we had the Bangkok Declaration in 2019, actually December, just before COVID broke through. And the IAPD, we call it the IAPD Bangkok Declaration. And the declaration is very, very clear in that an age-appropriate amount of 1000 ppm fluoride toothpaste must be used for all age groups. We do not have, except for places like Rajasthan and Andhra Pradesh, where you have a lot of fluoride in the drinking water. We have absolutely no fluoride in our drinking water, or extremely minuscule amounts. This is topical fluoride. This is not systemic fluoride. And today it's proven that the anti-caries effect happens mainly only with topical fluoride. It does not happen with systemic fluoride. So what we need is a very, very low dose of a topical fluoride that is delivered into the mouth every single day. What should change is the quantity of toothpaste. So up to 2 years of age, a rice grain size of toothpaste, just a chawal ka dana, roughly 2.5, 3 years to 6 years of age, a pea-sized amount, 6 plus a centimeter, and then move over to a full strip of paste. But remember to push the paste into the brush. So you push the paste into the bristles, so the paste enters the bristles, so the whole thing is not swallowed, the whole thing is not spat out into the basin, and then you spit and don't rinse. So this whole concern, my child can't gargle, my child can't rinse, my child eats the toothpaste, is not an issue at all. You're only using a rice grain amount of toothpaste, and you get the child to say thu, but slowly the child will learn. But if the child does not spit, there's no problem. In fact, children who are more cavity prone or who already have caries, the worldwide rule is spit and no rinse. So we don't even want that topical fluoride to get out of the mouth. We're using such a minuscule amount of fluoride. Now, until when does the parent brush for the child? This is another thing. Parents will typically come and tell me, doctor, he will not let me brush. वो करने ही नहीं देता है, उसको खुद ही करना है. And the first thing I will tell them is, अगर उसको खुद ही नहाना है, तो आप नहाने दोगे क्या? And the answer is always nahi, because they know that because they are not happy with the quality of the bath, right? They know the child can't do a good job, and bath is important to the parent. So I always tell them, when you make brushing important to you, you will know how to get it done from the child. Make brushing important for yourself, and you have to do it until the child is 6 to 7 years of age. So in the olden days, the bottom line was, when your child can tie their own shoelaces swiftly is when they can brush their own teeth. But today, children hardly wear shoes with shoelaces, right? Everything is Velcro. So I tried to think of examples. So I came up with when your child can button down their own shirt, when they can, of course, tie their laces, when they can eat roti and sabzi, poli and bhaji with 2 fingers, tear the poli bhaji and pick it up and eat it, or they can eat dal bhat nicely, neatly with their fingers. That is when they have the manual dexterity or the fine motor skills to do a good job with their brushing. So brush for them until 6 years of age, and brush with them after 6 years of age. This is the bottom line. That is the rule. And for children with disabilities and special needs, you need to do it for them until you know that the job can be done. And motorized brushes, like I earlier said, are very, very helpful. I also tell parents, don't discourage the child if they want to do it themselves. Keep 2 toothbrushes, 1 brush with which the child will play around, and the second brush is the brush with which you will brush for the child. But at all times, you meaning an adult who knows how to do it, has to do the job. Now, how will you brush? This is one thing. Everyone thinks they know how to brush, and almost no one knows how to do it right. What we are doing when we are brushing is we are removing plaque. Plaque is a very, very sticky biofilm. And unless you scrub the tooth surface, your plaque is not going to go away. So you need to flip the upper lip to reach the front teeth. You need to put your finger in and lift the cheek in order to get to the back teeth. There's no other way to do it. And for this, your child has to be lying down on your lap if it is a toddler, or your child has to be standing in front of the basin, and you need to be standing behind them with their head against your body if the child is older. I will show you a couple of videos, but if you want to tell your parents, your patients, you can direct them to we have an Instagram page for the clinic where I've put, it's just for parents and it is just for education, and I've put lots of videos on that page. That is the Instagram handle. So a lot of you may not be familiar with Instagram. I myself wasn't, but for Instagram, it's called the handle, and that is the handle at happy_tooth_clinic. So if you can direct them to it, all young parents know about Instagram handles. They can go and watch the videos. But just for your knowledge, I'm just sharing a couple of videos with you. And it's like very joyful to see these videos. It'll also break the monotony of me talking all the time. Sorry.
McDonald had a farm. E-I-E-I-U. And on his farm he had a duck. E-I-E-I-U. And a quack, quack here,
Baby's
and a
head
quack,
on
quack
your
there.
lap.
Here a quack, there a quack.
You have to
Everywhere a
lift the
quack,
lip
quack. Old
and lift
MacDonald
the cheek.
had a farm. Brush, brush, brush your teeth. Brush it every day. Father, mother, brother, sister. Brush it every day. Brush, brush, brush your teeth. Brush it every day. Father, mother, brother.
Of course, she has a beautiful voice also, so it's really lovely
It
to
helps.
watch her. Yeah, it really helps. Yeah, I'm just going to share one more video with you. This is how, so brushing is very inculcated in the West and the Far East and the more developed countries. And this is how you brush a child's teeth when they are really, really little. Right from the time the first tooth comes in the mouth. When it becomes a routine, children will never resist it. It's because suddenly you decided 2.5, 3 years of age, now I'm going to start brushing. It's like an invasion into the mouth for the child. So the parent is struggling, the child is struggling, and the parent simply gives up. So this is my colleague, a pediatric dentist from Belgium. He shared his grandchild's how his daughter's brushing his grandchild. I requested him to share it with me so that I can share it with all my parents. And I'm still waiting for one of my parents to send me a video so I can put it up on the page, because I don't want to put a foreign child's picture. But I wanted to share this video because this is how you do it for a little child. And see how comfortable this child is. This is how you brush a little toddler's teeth. There she goes lying down, the arms go under the legs like that. She's gently restrained, and see how happily she's getting it done. Because this is how it's been done from day one. So she's very, very comfortable. The parent and child spend only 1 minute of their lives on this activity. You don't need to waste more time of your life on this. That's it, all done. So this is the position for children. And I show this to all my patients. And look at this little sweetheart. She's even letting her brother do it because she's so used to it. You see that? So that's how you do it. Now, once it's a toddler, a little older child, this is how you will do the brushing. Yeah, so stand behind the child, flip the lip for the front, and do the, and again, flip the lip for the front teeth. Put your finger in and lift the cheek and brush all the teeth in 6 different parts. So all these videos are out there for parents to look at and to learn from. Okay, and we of course did this rap reel. We made this song to encourage kids and parents to brush. So I'll just entertain you with that, and then we'll go to more scientific stuff. Can you hear that?
Out, in, top, cross. That's how you brush like a boss. 6 sections, 4 strokes. Let's just get this right, folks. Out, in, top, cross. That's how you brush like a boss. Out, in, top, cross. That's how you brush like a boss. 6 sections, 4 strokes. Let's just get this right, folks. Out, in, top, cross. Out, in, top, cross. That's how you brush like a boss. Out, in, top, cross. That's how you brush like a boss. 6 sections, 4 strokes.
I enrolled my
Let's
whole
just get
family.
this right, folks.
That was
Out,
my mother,
in,
and
top,
that's my
cross.
son. So,
That's how you brush like a boss. 6 sections.
so the whole
4
family
strokes.
got enrolled
Let's
into this
just get
video.
this right, folks.
And toddlers like it so much.
That's how you brush like a boss. Out, in, top, cross. Oh, darling.
So parents tell me they put the music on in the morning and get their toddlers to brush. So this is how brushing needs to be done. And actually, it's just that we don't know. Otherwise, it's so easy to do it, right? Okay, now I'll get on to severe early childhood caries. What you and I, when we were in college, perhaps learned as nursing bottle decay, baby bottle decay. And it's actually called severe early childhood caries when it's up to 3 years of age, and early childhood caries when it's past 3. Now, why I want to quickly discuss this with you is that the very definition of dental caries and how we address it today and how we treat it has undergone a paradigm shift. Everything has changed about the way we address DK. And as pediatricians, I really want to share this with you so that you are aware. So if you refer your child for dental treatment, you know that these minimally invasive techniques do exist. And those children who can avail of them, that is what should be done, especially when those children are very, very small. So what is the definition? I will not bore you with too much theory or anything, but just for you to get the concept. Dental caries today is defined as a behavioral and a biological disease. It is biofilm mediated, diet modulated, it is multifactorial, it is non-communicable, and a dynamic disease that results in net mineral loss of dental hard tissue. What happens actually in that caries process? Dental caries, like I said, is a disease that occurs in the plaque biofilm. Yeah, when the biofilm is exposed to fermentable dietary carbohydrates, it causes a shift in the ecology of the biofilm. So we are gathering that biofilm 27-4 in our mouths. The moment there's fermentable dietary carbohydrate that the biofilm is exposed to, the entire ecology of the biofilm will change. And the bacteria from a balanced population of microorganisms, which is a low karyogenic population, it completely changes to a population of high karyogenicity. So this becomes a population that's very acidogenic and very acidic. That means this population of bacteria will produce more acid and it can tolerate more acid. Now, because of this production of organic acids, this promotes net mineral loss in the dental hard tissue, and that results in a carious lesion. Now, I'm just going to show you this figure, this diagram from this reference, because everything else that you see today is my own individual work. I don't pick it up from any source. So that's why I was just clarifying. Now, this is an early colonizing commensal community. So this is a nice, healthy community of bacteria in the biofilm. When this biofilm is exposed to poor oral hygiene, to karyogenic diet, what happens is extracellular polysaccharide mediated bacterial adhesion increases and the whole biofilm gets converted to a very sticky, very mature, very tenacious karyogenic biofilm. And that ultimately leads to the carious lesion. So what is causing this carious lesion? It is the poor oral hygiene and the karyogenic diet. So what's the solution? The only treatment for a carious lesion is to reduce the biofilm on the tooth surface, to reduce free fermentable carbohydrates. And here I will tell you, the first thing to reduce is the free sugar. The second is the brushing. If free sugar continues, you can brush all you want twice a day, out in top cross with the best toothpaste and toothbrush, it will be of no use. The free sugars have to be controlled. That is the only way you can prevent a carious lesion. So what are we as dentists doing? We are actually only repairing, because what we are doing is we are treating the sign and symptom of the disease, dental caries. The disease is actually occurring in the biofilm. We are only treating the symptom. And there is a lot of literature. Again, I will not burden you with it, but I'll just mention two very, very, very big studies that are like our landmark studies, which are completely changing the way we treat dental caries. And one of them is called the Fiction Trial. This is in 2020, just last year, year before last. And see what fiction is. Filling children's teeth, is it indicated or not? The very premise of this heading will startle you, right? That pediatric dentists are asking the question, is filling children's teeth indicated or is it not indicated? Because there are many situations where you could actually get away with not doing invasive dentistry in very, very little toddlers or in children with special healthcare needs. And I will go to that. And that is why I really wanted you to be aware of this. And this is the other one in 2020, which is the Organization of Caries Research, how to intervene in a caries process in children. And this is the consensus statement from there. So I'll just explain this very quickly to you. How does a carious lesion look when it first starts? This is how it looks. It looks like a chalky white spot lesion. Now you are going to see these kids. Trust me, we will never see these kids. And I know in a busy pediatric practice, you don't have the time to be flipping children's lips up and looking at these teeth. But if you happen to look at them, or maybe you're doing an examination of the throat and you look at these chalky patches on their teeth, this is a cavity. This is the first sign of cavity. This is the sign of acids removing the minerals from the teeth and the teeth getting chalky. These are called white spot lesions. And then the white spot lesions will break down like this and become yellow patches. And slowly you will see it progress from there to there to there to there. And often you will see stuff like this in the mouth. Now, this is not iron stains. This is not food stains. All of these are severe early childhood caries. All of these are dental decay. And the only way to prevent this is flipping the lip up and getting to those teeth and brushing along the gum line. Of course, stopping the baby bottle at 1 year of age, not letting the child sleep on the bottle after the first tooth erupts in the mouth. They can continue to breastfeed until 2 years or as long as the mother wants, but sugars have to be controlled. Excellent brushing has to happen. And once the teeth come in the mouth, it will be advisable not to let the child fall asleep on the breast. At least pick the child up, burp, but as long as, maybe wipe off those teeth, but as long as the teeth are really brushed well and you've not introduced any free sugar, breastfeeding is unlikely to cause severe dental decay as much as bottle is. So what do I mean by this whole new way of treating dental decay? When we have little children 1 to 3 years of age who come to us with severe disease, our first aim should be to avoid general anesthesia. So what do we do instead? We try to modify behavior. And when I say behavior, I mean inculcate good oral hygiene, good biofilm disruption, as we call it, and control free sugars. And we treat the active lesions and we try to inactivate them, meaning we don't need to do drilling and filling each time. There are chemical ways to inactivate the cavity. And I want to discuss that with you. Why are we avoiding general anesthesia? I'm sure a lot of you have seen that literature, because there are very important unanswered questions that remain on the effects of anesthetics on the neurodevelopment of children under 3 years of age. There are many studies going on right now about it, but even the FDA as of 2017 in their communication have said under 3 years of age, avoid general anesthesia if possible, and definitely avoid it for more than 3 hours. I mean, if it's life-saving or something, that's a different thing, obviously. So what happens when there are these kind of cavitated lesions in little children that come to us, like all of this, and I'm sure you see these. The moment you see these, please refer the child to a pediatric dentist quickly, because in the next couple of months, the child's going to have a big abscess, the lips are going to be swollen, and then it comes to a point where, you know, we have to take the child into the OT. There is no other way, and we want to avoid that. So this was a really little baby, not even a year old, about 8 months of age, when the baby first came to me with severe early childhood caries and this soft decay. 10 years ago, I would have gone in, removed all the decay, maybe done a root canal, maybe extracted these teeth. But today I will scrub these teeth with what is called silver diamine fluoride. This is a solution that arrests the dental cavity. It prevents further decay, and it of course acts as a dentine, it decreases hypersensitivity. But what it also does is changes the color of the decayed tooth jet black. So this baby, at 8 months of age, when they came to me and I applied silver diamine fluoride, that is how the baby looked. Now, this is shocking, right? Because you send the child to the dentist to get pretty white pearlies in the mouth. But our aim here is to control the disease. If I need to give her caps and make everything beautiful, I need to take this baby under GA, because this baby is too small and I can't do invasive work, give a local anesthetic and drill and remove the pulp. That's not happening. But this tooth is not yet infected. I have caught the tooth before the infection has set in, so I can apply SDF. We call it SDF, that is silver diamine fluoride. And in 3 months, just look what happens. As the tooth continues to erupt, you can see lovely, healthy tooth there. All these are pictures from my textbook, and that's why it's referenced there. But you can see healthy tooth there and look at this amazing thing at the end of 1 year. Now, 20 years ago, this would not be amazing to me. Making these teeth look beautiful I would have felt very proud of. But today I feel proud of sharing these cases, because what have we done? We have prevented the spread of the disease, we have managed the disease, and we've completely avoided general anesthesia in this 1.8-year-old child. We treated the disease, we avoided general anesthesia, and that is the best service we could have ever done for this child, right? Am I seeing this? Okay, now the use of SDF has received breakthrough therapy status by the US FDA, and the WHO, as late as July 2021, has for the first time listed SDF as a treatment alternative for addressing over 3 billion people with untreated tooth decay all over the world. Someone's mic is on. Now, again, another picture, 2 years after SDF treatment, look at the remaining teeth, all caries free. So now I have treated the disease because there's no new lesions, right? Meaning I have worked with the parent to treat the disease. Only the parent can treat the disease by managing sugar and managing oral hygiene. But we have stopped the decay, and this is how it was. And if there are any dentists out there, or if you shared this with your dental colleagues, they would tell you that if they took an instrument into these two lateral incisors, they would have been in the pulp. But right now we are treating these teeth so minimally invasively, and this is in the best interest of the child. We have not used a drill at all. The child has sat on the parent's lap and got this treatment done lap to lap. Now all children will not be as adorable and as cooperative as this child, but many of them are, and this child was. This is another situation where it was terrible, just the SDF, and then of course, by 3.5, 4 years away, the parent is concerned about how ugly the teeth are looking. We can do beautiful restorations and make the teeth look lovely. These are zirconia caps we do to make them look good. SDF is very, very useful in individuals with special healthcare need. And by the way, it's great in geriatrics. In the geriatric population where there's severe sensitivity in cervical lesions, that is cavities along the gum line, SDF works very, very well in these situations. It works miraculously in special healthcare needs. So the point here is that with every tooth that has a caries lesion, today I weigh my options and see and try to strike a balance between the treatment choices I have and what would be the best thing for that particular child. So I'm looking at my choices and the consequences of those choices. So it doesn't mean we don't do all the beautiful dentistry. Of course we do. We put beautiful crowns, we do root canals, we see them over extended time. This is a 4-year follow-up. So we do space maintainers, extractions, we do everything that is required to be done. But we always weigh our choices because now we have such a large bag there of treatment choices in front of us. And we try to be minimally invasive, especially in the very young children and in children with special healthcare needs. Now, is severe early childhood caries preventable? And honestly, this is where you really come in. I know as busy practitioners, you're looking at the whole body, and the mouth is a very, very little part of what you do. But again, they come first only to you. So once you know about this, at least for the patients you have the time for, you can at least spread the message. And of course, we all know that educating the mother, the parents rather, why the mother, the pregnant family about how to prevent dental decay would simply be the best. Again, in India, that becomes very difficult. But if they come for prenatal preventive programs, nothing like it. The second is to recommend sugar control. The third is, of course, oral hygiene. And these have known to significantly reduce dental decay. The first dental checkup should happen latest by the first birthday. We do anticipatory guidance. That means we are showing the parent exactly how to brush. It doesn't matter whether the child is this cooperative or this anxious and crying. We teach the parent how to hold the child down and do the brushing despite the crying, because the message needs to go that this is not negotiable. Whether you like it or not, beta, this has to be done. You help me, it'll be faster. You don't help, it'll take more time. And slowly the child learns that they have to cooperate. Children's teeth should be brushed from the time the teeth erupt with a fluoride toothpaste, like I already told you, performed only by the parent caregiver, at least 1000 ppm of fluoride. Now let's come to the sugar control. And this is where I think all of us are really poorly informed, because there are three kinds of sugars. One is the intrinsic sugar. That is the more complex carbohydrates that are present in the structure of our fruit and vegetable. These are very complex and very hard for the bacteria to ferment. So they are the good sugars. So children until 2 years of age should only be given intrinsic sugars. That is sugars present in fruit and vegetables. So we tell parents, you want to sweeten a porridge, cut bananas and put them into it. Cut fruits and put them into the porridge, but don't sweeten with artificial sugar. Don't sweeten with gur. Gur is also free sugar. Gur is just less caloric than white sugar, but white sugar comes from gur. Gur is less refined than white sugar, but gur is also sugar. So all forms of free sugar, whether it is gur, whether it is honey, or whether it is all the other sugars. The third is the extrinsic or the free sugar. These are monosaccharides and disaccharides that are added to food and to beverages by the manufacturer, the cook or the consumer. That's the WHO sugar definition, and which is naturally present in honey, in syrups, in fruit juices, in fruit juice concentrates. All these are free sugars, and all of these will cause decay. There is someone's, what is the scratch that's come on my screen? There's someone's pen has marked my screen. I don't know. Okay, thanks. Avoid serving food. So the rule should be, and this is the WHO rule too, avoid serving food and drinks with added sugar until 2 years of age. Sugar is highly addicting. So when it becomes a sugar-oriented household, you are giving jaggery with every meal. It's not the jaggery that you put into the dal. That is fine. But if you have roti and jaggery, if you are giving sugar in other forms, which are free sugar, along with the rest of the meal, the child gets addicted to the sweet taste and they will want every meal sweetened. Then it becomes really, really difficult. Sugar in fruit is honestly the only good sugar. Biscuits are one of the biggest reason for decay in our country, because biscuits are introduced as the first finger food, whether it is Marie, glucose, Monaco, Khari biscuit, or it's your chocolate biscuits, they are all maida and sugar. And they are really disastrous because they are very sweet and very, very sticky. Then whether it is jam and roti, or it is honey, or it is Nutella, or it is sweets, chocolates, and all the rest. Also, the stickier the sweet, the worse it is. So a bowl of ice cream, or let's say a piece of cake, is far better than a biscuit or a lollipop or a candied sweet, because they are really sticky and they will stay in the mouth for hours together. Lastly, it doesn't matter how much you give the child, because standard parents will say, doctor, itna hi diya main, itna hi leta hai wo. But itna hi wo lega, that is enough to coat the teeth. It is not how much they have, but how many times the sugar is given. So in 24 hours, if there's a constant intake of free sugar, the pH of the saliva will constantly become acidic. And every time the pH drops, there is an acid attack and there is demineralization. So you don't want repeated attacks. So I tell them to binge at one time. It is not how, so instead of many, many times in a day, one time is your binge time, and give the child a lot of dessert in that one time. Of course, bin the bottle at 1 year of age. Breastfeeding can go on like we discussed, but once the first tooth comes in the mouth, slowly reduce the middle of the night feeds. Typically, the child by then is having a whole meal in the night. So one good dinner, one good breastfeed, and then the child, you brush, and then the child sleeps through the night, and then the next feed is in the morning. That would be absolutely the ideal thing to do. Then there were questions about the indications for root canal treatment and whether deciduous teeth need extractions. I think these are very, very technical. I will skip these so that I can do what is more relevant to you. But obviously, when the tooth is infected, Sometimes we do advise pulp therapy in milk teeth. It doesn't always have to be root canal treatment. Root canal treatment is where you go into the root canals to treat, whereas pulp therapy could be less invasive, where we just take off the coronal pulp. It just depends. Often we do extract baby teeth because it is more safe for the permanent developing tooth bud to remove that focus of infection and put a space maintainer there rather than to do a root canal treatment. So we do that too very often. There was another question, I think, from the pediatrician at Nanavati, and I was really thrilled when I got this question about molar incisor hypomineralization. Now, this is, should we suspect it? How do we diagnose it? Was her question, and I was really, like wowed by the question that a pediatrician is aware about MIH, because MIH is something that is on a rampant increase. So I just thought I'll quickly touch upon molar incisor hypomineralization. This typically is seen in the young permanent teeth when the child is about 6, 7, 8 years of age, when the incisors start to erupt, the permanent incisors, and simultaneously the permanent molars start to erupt in the back. Now, these molars and incisors become hypomineralized. So it is a developmental quantitative enamel defect where there is a reduced mineralization and inorganic, there's a reduction in the mineralization and a reduction in the inorganic enamel components. So the tooth erupts, it is not decayed, but when it erupts, the mineral content is less. So you have a very, very weak looking molar like that. These are your young permanent molars, and they are extremely sensitive. Very often they are discolored, and because they are weak, the moment they erupt, there is what is called post-eruptive breakdown, because as the child is masticating and chewing, the teeth just start crumbling away. This is very, very common now, and we are seeing it in primary teeth too. We do not know exactly why it happens, but here are the postulated theories. It is systemic. One says it is systemic in origin with a disruption in the amelogenesis of the teeth. It could be because of acute or chronic illnesses during the last gestational trimester. It could be exposure to environmental pollutants during the last trimester. Evidence suggests that there could be disruption in enamel hardening following the exposure to serum albumin in the formative, when the enamel is forming. So in 1 to 3 years of age, acute chronic illnesses and exposure to enamel pollutants could also contribute to MIH. The least impact of pollutants and all the other things happen in the prenatal stage, more in the perinatal, and greatest in the postnatal stage at 1 to 3 years of age. But it's really hard to pinpoint, but 1 in every 6 children worldwide suffers from MIH. And it can be quite devastating because these are your permanent teeth, and it is a lifetime of dental burden once you have MIH. So very mild, you'll see chalky patches like these in the permanent teeth. In a little moderate situation, you will see darker ochre yellow patches in your incisors and a little more post-eruptive breakdown in the permanent molars as they erupt. And in severe MIH, you'll actually see teeth like this that literally have no shape, and they are just so badly mutilated just as they come in the mouth. And if you notice, the rest of the teeth are not bad at all, but look at how terrible these molars look. MIH very often goes unnoticed until the child has so much sensitivity that they simply can't even rinse their mouths when they are brushing. And that is when they come to us and we detect MIH. So the question of the pediatrician about how to diagnose it, I think is very tough for you at that stage in a 6, 7, 8-year-old to open the mouth and check. But now that you're aware of it, at least you know that it exists. So you could refer accordingly. High doses of I'm just losing the first sentence on my slide. I don't know why. But vitamin D reduces, again, the odds of enamel defects. So prenatal vitamin D supplementation, they say now, is really, really good, like for so many other things, as a preventive intervention for enamel defects as well. Another question that surprised me and I was asked was, what is your art of treating small children in a smart and in a scientific way And I added, and yet in a kind and in a compassionate way. So they asked me this question. So I thought, again, I'll just share this video with you all about how pediatric dentists, we put in so much effort into getting the child comfortable with dentistry. I think you'll enjoy this video. So for a break, let me just put this video there for you. This is the first examination of this child.
Oh, yes, Dino should look big. Right, Dino? Yes. Yes, and then Didi, please put the light on. Light off. We're going to check Dino's teeth. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well done, Dinosaur. You did a good job, right? You opened your mouth so big, you helped us so much. You can close your mouth now. I've checked all your teeth. That's right. Shall we put the mask on for Dino now? Do you want to check Dino's teeth? Good. 4, 5. Well done. Good job, Dinosaur. Please close your mouth now. Shall we put the mask on for Dinosaur? There you go, Dino. Here's your mask. And should we give Dino a star? Yes, you're going to give Dinosaur a star? Lovely, Dino. You got a silver star for
I know you all must be thinking we don't have time for all this. We've got 100 kids waiting in the waiting room for us.
Yes. Right, and now it's Ira's turn. Come, Ira. Now we will count Ira's teeth. Right, Ira? Lie down. Nice. Very good job. Baba Black Sheep. Please open your mouth, Ira. Lovely one, child. Some light. Black Sheep. Have you any wool? Yes, sir. Yes, sir. 3 bags full.
But it's not always easy to get a child to go from there to there to there. So when we have very minimal work to be done, let's say in a child who's less than 4 years of age and very little dentistry to be done, we use oral midazolam sedation. We use these 5 milligrams per ml ampule. We mask the taste with your paracetamol or ibuprofen, and the child comes in first thing in the morning, completely nil by mouth. And what this does is creates anxiolysis. So the child is wide awake, responding to every command, but they're just in a happy, slightly more happy state. So they are more capable of tolerating the unpleasant stimuli of dentistry. And the best part is it causes anterograde amnesia. So, you know, after the treatment, even if we have forced the child a little bit to get something done, the child is really very comfortable and happy. And of course, we have these televisions on top. So the child is watching their cartoon. So he's just about 2.5 years of age.
Yeah, that was the same boy.
But these are all children who have very little dentistry to be done, very simple
Let's see your
dentistry.
stickers, Dash. How many did you get? So many.
So many.
You like your stickers. Like your stickers. Yes, you like them a lot. And did you like your new teeth? Huh? Can I see them? Can I please look? I can't see them. Oh, nice.
The other thing we do, and this we do every single day, this is the way pediatric dentists treat children the world over. And fortunately, in pediatric dentistry in India, this has now percolated, and a lot of pediatric dentists are either using inhalation sedation or we are getting there. Hopefully very soon it'll be part of training throughout the country. Nitrous oxide oxygen inhalation sedation is from a dedicated dental unit where we titrate the amount of nitrous oxide oxygen that we give the child. It is anxiolysis. The child is awake throughout and obeying every command, capable of managing all their reflexes. It is a drug-induced state during which patients will respond normally to verbal commands, although cognitive and physical coordination may be impaired. The airway, reflexes, ventilatory, cardiovascular functions are completely unaffected. The advantages of inhalation sedation: impeccable safety record for more than 50 years. I've been using it for almost 15 myself. Protective reflexes, that is your cough and swallowing reflex, remain intact. Anxiety relief and pain control. It's a comfortable dental experience. It eliminates the pronounced gag reflex. There's no hangover effect. Children walk out from here and go straight to school. The gas is eliminated immediately. Patients can carry out routine activities for the rest of the day, and you're reducing the need for general anesthesia. And this is perhaps the biggest benefit. You don't want children unnecessarily to go through general anesthesia in the operation theater. Not only the expense of it, you do not want general anesthesia where you can avoid it. So I'll just show you just for a second quickly how wonderfully inhalation sedation works. This is in my old practice. These are before COVID happened and before we all got into our...
For a second, it will feel like a mosquito bite. After that, it won't hurt at all. All right? And you watch Frozen. Okay? Good girl. Nice and wide. Good girl.
Because the problem is our work starts after the injection. It doesn't end with the injection like your work. We need to inject voluntarily and then the child needs to open for 1 hour to do the job. So when they get the shots, the local anesthetic done easily. Did you see? Of course, we are talking. It's never just the gas. It's like verbal anesthesia as much as it is the rest. Like our talking, engaging them also makes a big difference. But so that was just to give you an idea of how it works. Yeah, and this is another much younger child, again on inhalation sedation.
You can close your mouth now. Well done. Good girl. Great. Let's get the chair straight.
These are all Porter matrix
Nice.
sedation units. They are like...
Did you have fun watching Mommy? Yeah? And you were so good. You helped Auntie so much. Thank you. Oh, well. How big did you open your mouth? All your teaching, right? Yes, you can. How are you feeling in your mouth first, tell me? How do you feel? You feeling better? And
So this is bang after the inhalation sedation. You can see how alert and normal she is. That's the reason I shared that with you. Now, this was one area that I insisted I wanted to talk to you about, and that is traumatic dental injuries. I'm sorry to go to a gory image after that cute little video you just saw. But this is one area I want to talk to you about, because if the parent is already a patient of ours, or they know about us, then when a child has a fall and injures their teeth, they'll come rushing to us. Otherwise, you are their guys. You are their guys for everything, is it not? And they will come first to you. Where dental trauma is concerned, time is of essence. Time is critical. And when the correct first aid happens at the right time, it can make a big difference, especially in young permanent teeth, in children who are 6, 7, 8, 9 years old. If you do the right thing, meaning if you advise them on what has to be done, the correct thing to be done, it can be the difference between that person having their tooth for their whole life or losing their teeth. Because trauma is just such a critical time is so critical where dental trauma is concerned. It can be an extremely distressing experience for the child and parent. In the primary dentition, a high incidence of dental trauma happens from 1 to 3 years of age when motor coordination is developing and the child is learning to walk. In primary dentition, primary dental trauma, actually, it's pretty straightforward. Either the tooth is subluxated, that means it's slightly mobile. If it is excessively mobile, we simply extract it. We do not want any chances of aspiration or the child swallowing. And of course, if it is avulsed, that means the tooth is completely come out, we do not replant baby teeth. Then it is only about managing the bleeding. It's only about first aid, calming the parent and child down. And then, of course, do refer the child to a pediatric dentist so that a radiograph can be taken and everything can be examined. But that's about it. Now, when it is an intrusion, that means the tooth gets shoved into the bone, because at this stage, the alveolar bone is very soft. Depending on the nature of the trauma, the tooth can just get pushed completely inside. Very often, we wait for spontaneous re-eruption. So in these young children, the tooth can spontaneously re-erupt. Did you see how well it's re-erupted here? So we monitor it radiographically and clinically, await spontaneous re-eruption. In some cases, we do need to extract, but typically in intrusion, that's what happens. Like I said, what's more important is our young permanent teeth. 20% of all children up to 18 years of age will suffer some kind of dental trauma in their permanent dentition. And most commonly, it's between 7 to 15 years of age. At this stage, what happens is that the young permanent teeth are not fully developed. They are in the mouth, they have erupted, but their roots are not formed completely. So these teeth are called immature teeth. They are immature, but they are the permanent teeth, the lifetime permanent teeth. And therefore, time becomes very, very valuable in these teeth. So when we have trauma in the permanent dentition, between 7 to 10 years of age, apexogenesis is occurring. Apexogenesis means the root is continuing to grow. So the teeth have come into the mouth between 7 to 10 years, but they are not fully formed. The crown has developed, but the root is continuing to develop. And at this time when injury occurs, it can become very, very complex. One of the things that you will see maybe is when the tooth gets luxated. That means, see, it has completely shifted from in the mouth. If a child comes to you rushing like this, I mean, though you're not dentists, being doctors and seeing all kinds of injuries, it may not be that hard for you to gently reposition this tooth as best as you can. Just reposition and rush them to the nearest dentist. And pediatric dentists are a little more trained in trauma. At least some of us are very trained. So if you could rush them to a pediatric dentist, even better. If the tooth, so these are the three kinds. Trauma is a vast topic. We have an organization, the International Academy of Dental Traumatology and the Indian Society of Dental Traumatology. So it's such a huge subject in itself. But the three areas that I was thinking where you would really come in, one is to reposition a tooth when it's luxated. Second is when these teeth fracture. If a patient comes to you rushing after trauma with fracture, please ask them to go and look for the fragments, because we can reattach these permanent tooth fragments. They can be reattached. So don't forget, if they come with a broken tooth, go ask them, where is the broken piece? Most will say, oh, it's lying there. I didn't pick it up. Oh, it's with me in my pocket. Whatever it is, take the fragment and go to the dentist, because we can reattach. The third is avulsion. Avulsion is when that permanent tooth has come out completely from the socket. Being pediatricians yourself, if an avulsion happens in children is the time that we have the greatest chance of the tooth, of the body accepting replantation of that tooth. But again, time is of essence. So what must you do when a tooth is avulsed? First of all, reposition, like I told you, try and push it back, we will splint the tooth. Where a tooth fragment breaks, we will reattach the fragment. That is before the fragment, with the broken fragment, that is the reattachment. That was the tooth that was broken, that's the reattachment I have done. These are all my cases, by the way. Like I told you, everything is my own personal work. These are the broken fragments. This is the reattached tooth. What is the beauty of reattachment? It is minimally invasive. We are not even touching a drill to the tooth. We are literally just sticking the teeth back. And in a young permanent tooth that is still forming, we want to be minimally invasive. That is the best we can do for the child, is to be minimally invasive. So what happens if it's an avulsion and the tooth is out? What are the rules for storage? The first thing is to pick the tooth up from the crown, avoid touching the root. So tell the parent to pick it up from the part that is outside in the mouth and not to touch the root. And tell the parent over the phone to see if they can immediately push it back into the hole from where it came. Some parents will be courageous and they will do it. So at least encourage them and try and get it done, because the best place for that tooth to be is back into the socket. So if they can gently hold the tooth with the crown of the tooth, gently wash it under running tap water just for 30 seconds, and then push it back into the socket, because actually tap water is not good. You want an isotonic solution, you want saline or some other isotonic solution, but they will waste time if they go looking for it. So the best is if they can push it back into the socket from where it came. If they express inability, you can make out they're so hyper, they're not going to do it, ask them to come rushing to you. Wash the tooth in a bowl of saline and try and attempt to push it back into the socket from where it came. That's the best thing you can do. The second best is to rinse the tooth and put it in milk, cold milk, saline, or in the patient's saliva, meaning have the patient spit into a bowl and then put the tooth, soak the tooth in the patient's own saliva, and then replant it if you can. The moment you push it back into the socket, give them a handkerchief or give them a thick ball of gauze that they can bite into and rush to the dentist. Like I said, time is of essence, so let's not miss out. And that's why in trauma, I wanted to really include you and say you are really important to this whole subject. If the patient comes to you, please do the best you can. And now if replantation is not possible at the accident site, then place the tooth, like I said, in the storage medium. Okay, the best storage medium would be one that avoids dehydration of the root surface. So the best is milk. The second best is saliva, spitting into a bowl. The third best is saline. But if you can't get any of these, another good option would be contact lens solution. If it's a clean bottle, not one that's been lying forever. Contact lens solution is isotonic. Coconut water is isotonic. These are the things that I can immediately think of. I think of these, saliva or milk would be, I guess, the best. Another question I got was about halitosis, about staining, iron stains. So the thing is, when brushing is poor, iron stains will happen more. Iron stains happen more because the parent doesn't know how to brush well, the child is not cooperating, the parent is struggling with brushing. Otherwise, with good brushing, iron stains don't happen that much. If it's okay, and you can give me your opinion, if they can dilute the iron syrup in a little bit of water and then gulp it down, because the iron syrup is typically quite yummy and it's quite thick. So then you have the child, smacking it and keeping it for a very long time. So if they can rinse it and then time it such that brushing anyway follows or some other food follows. So after the tonic, if there is a little bit of the meal that's left or something that they're going to eat after the tonic, again, it will stain less. And if they brush twice a day, normally it should not be a problem. The problem happens, one, because brushing is poor. Two, because white spot lesions and initial decay will catch the iron stains the most. It's like a rough surface will catch staining more. Like if you put haldi ka water on a clean, smooth surface, it's not going to stain. But if it's a rough surface, it's going to catch stains. So already the child has initial decay, which is why the iron stains are catching so much. So that could be the other reason. We also have something called chromogenic stains. These happen in some children. These are chromogenic bacteria that are stain forming, but they're very, very safe bacteria. They're harmless and they cause these classic stains, but these stains typically happen along the gum surface and they're very dark brown or black stains, and they will happen throughout the mouth, black stains like these. We still don't know why these happen. And the only solution is to clean them off. So if it's a 1.5, 2-year-old child with chromogenic stains, I just teach them good oral hygiene. I don't want to subject the child to a cleaning procedure. It's not going to be comfortable for them and it's not pathological. So they can stay with it for a little while till the child gets older, and then we address it. Halitosis, many reasons for halitosis. The first reason is poor oral hygiene. Either no oral hygiene is happening or very poor oral hygiene. Then, of course, your inflamed tonsils could be another reason, upper respiratory tract infections. But honestly, those don't cause halitosis as much. Mouth breathing is another thing that causes halitosis. But actually, that is the other thing I'm passionate about and would like to share with you, because that's again an area, sleep disordered breathing, where you really come in. Trauma and of course dental caries are three areas where you guys are going to be the ones who see patients long before we do. And for that, I want to, in the end, Dr. Gokarna, do I have time now? It's the last topic. I need about 10 minutes more. Yes, you're mute, so I can't hear you. Perfect. Yeah, perfect. So this is another area that I am very keen on discussing with you. And I want to talk to you about the tongue and sleep, both of these things. The tongue is like, for us, of course, it's a very big organ, but for the whole body in any case, and even for you, the child, that's one of the first organs the child uses, right? To latch well and to breastfeed. So it's very important for you and for me. The tongue has 8 muscles. Feeding, it's used for feeding, for breathing, for speaking, of course, for sleep, for posture, yes, for posture as well, and development of the dental arches for the orofacial complex. I want to discuss tongue ties here, which I'm thinking you must be guessing, she's going to talk about tongue ties. So I want to talk about tongue ties here because I think traditionally in all our training, in your training and in mine, and even till today, the young pediatricians and young pediatric dentists and dentists in general are not trained about the latest evidence and the latest that there is to know about ankyloglossia or about tongue ties. And it's not only about latching and breastfeeding, though that is very important. I mean, it is critical. It is not just about speech. There's a whole lot of things that are tied around that one tie, that tongue tie. So the anatomical definition that all of us were taught is that the frenum is a fold of mucosa that connects the midline to the inferior surface of the tongue. The midline of the inferior surface of the tongue to the floor of the mouth, and that's called the lingual frenum. And when that frenum is unusually thick, when it's unusually tight or short, it is called a tongue tie. This was the classic definition. And we've all been taught that if we saw an image like the one I've put there on the screen for you, that is a tongue tie. Why? Because you're seeing the anterior tip of the tongue is tied. But this is only an anterior tie. This is not the only kind of tie that exists, because the definition of a tongue tie is a functional definition. It is not a visual assessment. It is a functional assessment. And the new definition today is that a tongue tie or a frenum, is an embryological remnant of tissue in the midline between the undersurface of the tongue and the floor of the mouth that restricts normal tongue movement and hence affects function. It is all about function. It is not about how it looks. This tongue tie, again, that I've put for you, I know that you would have picked up and said, oh, that's a tongue tie. But there are many that will not look like this, and they are still tongue ties. It affects function. When it affects function, that is a tongue tie. So what is important is there has to be functional limitation in addition to an anatomical finding in order to meet the criteria of a tongue tie. So what are the functions we are talking about? Protrusion is something all of us were taught to do, to tell the child, stick your tongue out, right? So the child sticks their tongue out, this is a tongue tie, right? Because the tongue is getting pulled anteriorly, you're seeing a heart-shaped tongue, that's again a tongue tie, you're seeing like a W-shaped tongue. That's a great mouth. There's no tongue tie there. But guess what? That is a tongue tie too. Why? I'll go to that. Because more than protrusion, what is important is elevation. This child can elevate only that much. She can't elevate at all because the tie is so thick and it is tied so badly. This child can elevate, but very little, because the tongue is so badly tethered to the floor of the mouth. And this boy here can elevate, but he needs to close his mouth in order to elevate and stick his tongue up to the roof of the mouth. Now, why is this so important? I'm coming to that. Elevation or lifting the tongue is the best quick test to screen for a tongue tie. So if a child obviously has a latch problem, an infant, you're not going to ask them to stick their tongue up. It's an infant, so you have to do a physical examination. But apart from children who are infants, when they're toddlers, the best toddler and above, the best test is for them to elevate their tongue or lift their tongue up. That is the best screening you can do, a quick screening for a tongue tie. It is all about elevation. Why elevation? A child who can stick out her tongue or protrusion can still have what is called a posterior tongue tie. The posterior tie doesn't happen in the throat. It is just called a posterior tie because, and I will explain to you, what is important is for them to elevate their tongue. Because even if they can stick their tongue out, they will still suffer from issues of feeding, issues of speech, and issues of sleeping. The tongue should elevate freely to be close to or to be touching the palate when the mouth is maximally open. When my mouth is wide open, I should be able to elevate my tongue and stick it up onto the palate. Elevation is the key movement for breastfeeding. It is the key movement for solid feeding. It is the key movement for restful sleep. And it is the key movement for speech. In an infant, the only way for you to check for a posterior tie when you are seeing breastfeeding issues and you do not see an anterior tie is, of course, the first thing is the symptoms. The child's symptoms, the mother's symptoms, and the feeding symptoms. And I'll just spend 1 second on it because that's not the focus today. But the only way to examine is to physically stand behind the child, 2 fingers on either side of the frenum, and to lift the tongue. If the tongue tip if you can elevate it to touch the palate and you do not see this thick rope, then the tongue is fine. But otherwise, this particularly is a posterior tongue tie. Because you and me, we all know, we've been taught, oh, if you have a tongue tie, you can't lick an ice cream, maybe you can't blow a wind instrument, and you can't French kiss. These are the standard things that socially have always been told, and these are important, but they're not as important. We also know that if you have a tongue tie, nursing becomes an issue for babies, and speech can be an issue for some children. But this is not all. Children may compensate with feeding. Children may compensate with speech, but all children who have a tongue tie will not be able to elevate their tongue and suction it against the palate. And that is the only place your tongue should ever rest at. And I'm coming to that. The other issues that a tongue tie will have is children, toddlers, and other older children will have issues with eating. They may have reflux, they may have heartburn, they may have digestive issues. They will have sleep disordered breathing, which may land up in giving them enlarged tonsils and adenoids, maybe multiple ear infections, neck ache, migraines as they grow older into adults. These children may have dental caries, greater chances, and of course, orthodontic issues. I'm just going to deal with the first 3, discuss the first 3 with you, because the dental issues and orthodontic issues are, of course, our headache. The tongue in breastfeeding, all of you know, and you know far, far more than me. You are the experts in it. But when the tongue, how does the tongue suck the milk out of the breast? The tongue elevates and it presses against the palate. The middle and posterior, the mid to posterior tongue controls the movement of the fluid for a good swallow and for optimum airway protection. We know all this. But I don't do as many infant frenectomies as I would like to, simply because they are not referred to us. But we continuously do the frenectomies for older children. And I want to share this with you because this is an area where knowledge about the tongue tie and the airway is really lacking. And of course, sleep disordered breathing is lacking too. But we know that tongue ties affect babies and mothers, the baby mother dyad in a significant way. And mothers will have pain during breastfeeding, and pain is not normal. There should never be pain during breastfeeding. Mishap in nipples, there could be clogged ducts, therefore low supply of milk because the child isn't suckling enough. Pain during the first latch, pain on nursing, baby prefers one side to the other. The child's symptoms could be colicky, excessive gas because they're sucking so much air because they're not able to create a good seal. There could be noisy breathing. They may snore, they may mouth breathe, and these infants may have reflux, and they may be diagnosed with thrush, though it's not thrush, it's just the milk lying on the the dorsum of the tongue. Because of the tongue tie, the child's not able to clear that area. There'll be feeding symptoms of a poor latch, of clicking and smacking sounds, of biting and chomping on the nipple. The child will slide off, slide on, the child will fall asleep, there'll be blisters, etc. So all this is about infants, but I'm not getting into infants today. Of course, you need a good lactation consultant, and I'm sure all of you work with lactation consultants. So even when we release infantize, it's not just about the release. In fact, it is never about the release. It is all about the therapy that happens before and after the release. So that's a separate subject. We won't get into it today. I'm just going to get into slightly older children and how it affects, because I know parents come to you saying, doctor, the child takes 2 तास लावतो जेवायला. He takes 2 hours to chew his food. 2 घंटा खाते ही रहता है. एक ही बाजू में खाना रखता है. Jaldi khata nahi, or the kid doesn't like this food or that food. Many children with tongue ties are picky eaters. They will avoid certain foods because these foods are so hard for them. Foods that scatter in the mouth. For example, for some children, it's not for all. Like say khakra, you bite into khakra, it breaks into pieces. Like corn chips, you bite into it, it scatters into pieces, or papad. Then sticky food. One I can think of is something like peanut butter. For those who have it, okay, very, very sticky consistency because they're not able to clear it from their palate. Mixed consistency foods like grapes, where there is a skin and then there's a pulpy fluid inside. So when they bite it, they're not able to manage the skin and the pulp. Or mixed texture food, like say very liquidy dal bhat, varan bhat, okay, which is very fluid. They're not able to manage both, or they're not able to manage pasta and sauce. So mixed textures of food. They'll be slow eaters because with severe ties, they will have an up-down chewing motion instead of a circulatory path. And it takes forever for them to chew that food in order to swallow it. So they become very, very slow eaters. Many of them will chew unilaterally because it takes them time. How does the food go to the other side? The tongue is what takes it and moves it from the midline and moves it from one side to the other. So when there is a tie, the tongue is unable to function very well and the child will unilaterally chew. And many children will pocket their food. They'll pocket it and just keep it there for a long time. Many will wash down the food with water. So these are all feeding issues. Now let me come to breathing, which is what I've been like desperate to get to. Now, there is a normal tongue resting posture. And as you are all listening to me, and I'm the only one doing the talking, hopefully right now, you will notice that your tongue is suctioned against the palate. Our tongues should rest against the palate 24/7, except when we are talking or except when we are eating. The tongue is resting against the palate. The tip of the tongue, that is the incisive papilla, and that is what we call, excuse me, the end spot. It is also called the spot. That is the spot where your tongue touches when you say no or n. That is the end spot. The tip of the tongue will rest against the end spot, and the rest of the tongue is suctioned along the palate. The tongue is suctioned all around the palate, sucked up against the palate in the day and when we sleep at night. Now, how does a tongue tie affect the airway? You know the ideal position. The ideal posture should be lips together. The child should never have the lips apart. When the lips are apart means the child is mouth breathing, and mouth breathing is poor quality air that the child is taking in. We want only nasal breathing for all our children. So the lips should be together. You should be peacefully breathing through the nose, and the tongue should be suctioned against the palate. So look at this diagram here. Lips together, breathing through the nose and the tongue against the palate. This is the ideal posture. When the tongue is suctioned against the palate, what happens is our airway opens up nicely and the airway is wide open and the child is able to breathe well through the nose, which is the way breathing should happen. Now, when there is a tongue tie like this, the tongue is pulled down. And when the child is asleep and and it's not about children alone, even adults with tongue ties, it's the same thing. All the muscles are relaxed. The tongue will fall backwards into the posterior pharynx and it reduces the airway in the posterior pharynx. So that is how the airway gets reduced and the child is unable to breathe through the nose. So immediately they will start breathing through the mouth. A tongue tie will pull the tongue down. During sleep, as the muscles relax, the tongue falls backwards. It blocks the posterior pharynx, leading to varying degree of airway obstruction. This causes turbulence of air and mouth breathing. The mouth breathing will further perpetuate microtrauma to the tonsils and the adenoids and tonsillar enlargement, which will further perpetuate mouth breathing. And we know that mouth breathing is very, very poor quality breathing because you're breathing the same air, but there's a vast difference when we breathe through the nose and when we breathe through the mouth. When we breathe through the mouth is when we have sleep disordered breathing. So oxygen deprivation causes the brain to trigger bruxism in an effort to arouse the child or the adult to a lighter state of sleep, and also protrudes the lower jaw. When you're grinding teeth or bruxing, the mandible comes a little forward, which again opens up the airway. So these are classic signs of sleep disordered breathing, and a tongue tie will contribute to them. But there could be children who are highly allergic and atopic, though they say a tongue tie will further increase allergies. But children who are atopic and who have constant allergies will have an inflamed airway and start mouth breathing. When they need to breathe through their mouth, they cannot rest the tongue up against the roof of the mouth. All of these children with blocked airways will have a low tongue posture. When the tongue is not suction against the palate, your palate will not get into a beautiful wide U. And this is how we want the palate. We want our palate to be a wide U. Instead, all children with sleep disordered breathing and tongue ties will have a narrow, high arch, V-shaped palate. Now remember, the V-shaped palate is also the floor of the nose. So when the palate is narrow and high arched, there's obviously very, very narrow nasal cavity you have. So there's again turbulence. Nasal airflow gets compromised. Again, these children will breathe further through their mouth. Sometimes there's nasal septum deviation because of this whole scenario. All of this is interlinked because this whole craniofacial complex is relying on each other, and everything is they are interacting with each other. This pattern of mouth breathing will continue through childhood into adulthood and land up in obstructive sleep apnea. Like I said, a big difference between nasal and mouth breathing, and we simply ignore mouth breathing in our work. When the lips are apart at rest, the child is watching television, the lips are away. Child is concentrating on a task, the lips are open. The child is mouth breathing. This is completely unhealthy because the nose warms the air, filters the air, humidifies the air. It enhances oxygen absorption to the lungs via nitric oxide that is produced in the sinuses. It is responsible for proper craniofacial development and head posture, like I said. Poor oxygenation will lead to very poor quality sleep. And I will talk to you about the signs of sleep disordered breathing. But poor oxygenation to the heart, brain, and other organs will stress, and they will get stressed because of oxygen debt. There is a sympathetic dystrophy where the body is subjected to continuous release of adrenaline during sleep. It affects growth, it affects development, allergies, asthma, eczema, it affects intellect, academic performance, behavior, and much more. And we are seeing this continuously in our screening of SDB or sleep disordered breathing. After full tongue tie releases, and SDB doesn't need to occur only because of tongue ties, but this is a one big contributor. But with tongue tie releases, children sleep more deeply, they snore less, they exhibit fewer movements in their sleep, they feel more refreshed in the morning. Often they concentrate better and are less hyperactive in the day, and significant functional improvement in speech and solid feeding. Now, just before the last 4 slides, Dr. Gokarna, these are classic. I'll just show you the tongue ties that we regularly do. Now, what is good about the way we treat tongue ties. Tongue ties are treated by ENTs, by pediatric surgeons, by plastic surgeons. But typically they all use general anesthesia. They take the child into the OR, into the operation theater, and then they release tongue ties. We release tongue ties on the dental chair, no GA. The child wears the nasal hood. He's breathing nitrous oxide oxygen. Inhalation, sedation, we numb the tongue. Just a few drops. We do far more when we extract a tooth or do a root canal treatment. And we release the tongue tie with a simple diode laser. It doesn't take more than 10 minutes. All our energies are spent into the therapy that we do before the tongue tie release and the therapy that we do after the tongue tie release. Because releasing the tongue tie is not the end of it. It's only the beginning. You do not want reattachment. With tongue ties, the issue when a lot of times it is released is there is reattachment. Like all wounds will try and reattach when they heal. We do not want the tongue tie to reattach, right? We want it to heal in its new position. We open up the diamond and we want it to heal in the new position. Also, the tongue now has to learn new movements. It has never gone and suctioned against the palate. So we do what is called oromyofunctional therapy. These are breathing, lip and tongue exercises that teach the tongue to sit up against the palate, the lips to close, and the child to start breathing back through their mouths. But this is the next day after releasing the tie. That is the diamond-shaped wound the day after the laser release. This is 1 month after the tongue tie release. Notice the extension, but that I'm not worried about. What concerns me, as you know now, is the elevation. In the beginning, the child could not elevate. He was lifting the middle of his tongue to touch the palate when I was asking him to. Now he can actually lift his tongue and touch the palate. This is at 1 month. But look at how beautifully he can do it at the end of 1 year. This is the preoperative before after, and this is at the end of 1 year. That's another child with a thick tie, just a 4-year-old on the dental chair. This is the day after. She doesn't know how to lift the tongue because this is all she's ever learned. It's the therapy and the exercises that get her at 3 months to lift her tongue so beautifully up with a wide open mouth. Remember, the mouth needs to be wide open. And that is at the end of 1 year, wide open mouth, tongue up on the roof of the mouth, and that is the extension. These are children, many of them with speech deficits, but many have no speech issues. They will all have breathing issues. They will have sleep disordered breathing. And I'll just go through those symptoms with you in a minute. This is another child, again, preoperative. The child extends. This is the child I showed you earlier. So you will say, oh, there's no tongue tie. Why? Speech is good. The child speaks very well. The child eats fine. The mother's not complaining. But the child mouth breathes. The child bruxes or snores in the night. And this is all the elevation he can do. This is the day after the release. This is at 1 month. Can you see with a wide open mouth, the tongue is right up on the roof. And this is at 1 year. See how beautifully he's elevating. And that was before, and this is after. This is what we aim for when we release tongue ties. We screen for sleep disordered breathing in our practice because very often we'll end up being the people who are diagnosing sleep disordered breathing. We have loads of literature on it, and I'm very happy to share it with you if you'd like. But the classic signs of sleep disordered breathing and open mouth posture and mouth breathing, they will always position their head forward because then that helps them breathe better and open up their airway so their posture goes for a toss. They may have noisy breathing. Some will snore, some will grind their teeth or grux. They will almost always have restless sleep. They will toss and turn in the night. They will never sleep like logs. Some will have frequent arousals in the night. Some will have somnology. Some will have nightmares, enuresis, bedwetting, or drooling. And this is way into when they are 7, 8 years of age and they're still bedwetting. They may have difficulty waking up, daytime sleepiness. Many are diagnosed with ADHD, whereas they just have SDB. When you and I have endless nights of poor quality sleep, we'll be dull in the day. When children don't sleep well in the night, they are hyperactive in the day. Very often they are diagnosed with attention deficit or attention deficit hyperactivity, but they only have sleep disordered breathing. They may have disinterest in eating. They may be irritable, angry, headaches. Many will have tongue ties, many will not, but they will all have reverse swallow. That means they will not swallow correctly. What is a correct swallow? Teeth together, tongue up on the roof of the mouth. You suck up against the roof and you swallow. That is a good swallow. They will all thrust their tongue forward, squeeze their lips and cheeks and swallow. That's a reverse swallow. Some may have speech issues. Many will thumb suck and digit suck simply because when they do it, they lower the mandible in the night, and it makes it easier for them to breathe in the night, and therefore they find it so hard to give the habit up, even though they are 7, 8, 9 years of age, and they'll all have dental issues, high arch palates, severe crowding, and cross bites. So when the adenoids and tonsils get inflamed, the air is struggling to pass through, and this is just one small example of this child. Chaitesh, who had snoring, who didn't have bruxism, open mouth posture, restless sleep, he would kick the parents in the sleep. Madam to लात मारतो आम्हाला झोपताच येत नाही. रात्रभर आम्हाला लात मारतो. खाली ठेवलं परत उठतो. They'll all be light sleepers. They will never get into deep sleep because the body doesn't let them get into deep sleep because they're oxygen deprived. Some will have frequent arousals. He was sleep talking. He had nightmares. He would bedwet twice a week. The mother would set an alarm to wake him up in order to sleep, and look at the posture in which he's sleeping. Some will just sit up in the middle of the night. They will have awkward postures, and just 2 weeks of nasal spray, of corticosteroid nasal spray, and he's actually sleeping like an angel. And what's more, the mother's sleeping like an angel. So SDB is something we need to diagnose, check the airway. You guys are the best at it. We refer to an ENT so they can check the airway, but the aim is always lip sealed, nasal breathing, and tongue suctioned against the palate. We do oromyofunctional exercises. These are charts that we make for kids. We have exciting exercises that they have to tick and do. There's a lot of motivation you need from parents as well in this. And then we intervene early in the mixed dentition because all these children have cross bites like this posterior bite here and open bites because they have enlarged adenoids. And it's not about kissing tonsils. There's this child with severe SDB and an arch that was in total posterior cross bite. I send them to the ENT who does sleep disordered breathing. And we both agreed that he was suffering majorly and he needed an adenotonsillectomy. But the pediatrician told them, no, the tonsils are not kissing. So you don't need adenotonsillectomy. It doesn't have to be kissing tonsils. If the airway is obstructed and you're seeing all these signs and you're seeing it is not responding to nasal sprays, the child needs to breathe and sleep better because good quality of sleep contributes to neurocognitive development in a growing child. And it's just far too important. We see 2 and 3-year-olds with cross bites like this. We treat them very, very early. So the first dental checkup at the time, the first tooth erupts latest by their first birthday, do send them to a pediatric dentist so they get early attention. And like all of you out there, my motto always has been that I will do for every child what I would have done for my own child. I'm sure all of you believe the same. In all my lectures across the world, I call this the My Child principle. Every time we make a decision about a treatment plan for our children, we must remember the My Child principle. Thank you so much for your attention. I hope you enjoyed it. And Dr. Gokarna.
Thank you so much, Meenakshi. And today when I saw this presentation, I thought there was a lot more I must have missed last time. So there were many more.
I did add a little more, I must say. I added a little more on sleep disordered breathing, ties and stuff like that.
Oh, it was so amazing. I'm sure most of us, after I heard your last talk, I picked up 3 tongue ties and 2 of them were sisters. And the mother told me that, even I have a tongue tie. I sent them for tongue release and they were slow eaters and they were not snoring, but one of them was a slow eater and one of them was, I don't remember, but had some other problem. So
Doctor, the therapy, don't forget, just remember this in future because it will reattach. The problem is, and you'll see this with infant releases. So people say infant releases are a hoax because for a week, the mother says, oh, the latch is great. There's no pain, the child, and then slowly it gets worse because it's reattaching. Therapy is required. Without therapy, it will not happen. They need to stretch the wound. There are wound stretching exercises. There's tummy time they need to do. There are other exercises to ensure that the release is maintained.
Yeah, both of them were about 3 years of age and they went to a pediatric surgeon who ensured that they would get post surgical exercises. So that was also part of the thing that I learned a lot last time, and there were so many lovely slides. So there were some questions in the chat. and I think I'll take them. Best wishes, Dr. Hemant Joshi. Life of a tooth from secondary dentition if brushed regularly. So can you, what is the lifespan of a tooth if it is well managed?
Permanent tooth?
Yeah.
Up to our last day, really.
Yeah.
We can,
Yeah.
peacefully pass away with all our 32 intact.
Oh, super. So no DK brand is available in the market. Is it really a good one to
Which
prevent
one?
decay? No decay. No decay.
Okay. Those are those tablets. There's no evidence for it.
Okay.
The bottom line is free sugar control and plaque removal. It's so simple and yet so hard to implement because it's just so tempting for parents. Parenting is just getting harder by the day, and you all can all see the difference in the parents we meet. I mean, say 20 years ago or 25 years ago, I met you, but you know how the parents we meet today, right?
Yes.
They are also so challenged in the demands that they face. So it's hard for them. So it's easy to fall back on refined food. It's easy to cultivate habits that get hard to break. But all free sugar will cause decay, refined carbohydrates.
Yeah. So Dr. Hemant Joshi has asked, please list free sugars.
That she is
Okay.
done.
Sure. Perfect. So free sugar will be sugar in milk, Bonvita in milk, Horlicks in milk, all the additives that we put in milk, and plain white sugar that you put in milk, jam that you put on your bread, chocolate spread that you put on your bread, cereal that you give the child to eat with milk. So we are not saying in 24 hours, don't give free sugars. Be aware of the free sugars. Try and not give unnecessary free sugar with every meal. Biscuits are all free sugar. You give jam with the poli, with the chapati, just to push the chapati in. You give good with the chapati, gold with the poli, just to push the poli in. All these are free sugars. Sweets are free sugars. Chocolates are free sugars. Prasad is free sugar. Okay, prasad is free sugar. Okay, mithai, sweets, chocolates. So our aim is what? The sugar should be the less sticky, the better. Like I said, a bowl of ice cream, a piece of cake will stick less than a lollipop, like a candied goli. You know, those orange candied sweets and those Ravelgon sweets, they are so sticky and so intensely sweet. The child will bite into it, it will glue onto the teeth. The less sweet, less intense, less sticky, the better. And the less number of times altogether. So if you're having one load of sugar, like a snack time in the evening, you're giving bread jam because you can't help it. You have to give bread and jam. Give at least a fistful of nuts. Give shengdane after that. Give chana moongfali after that. Okay, or give some makhana after that. Give some popcorn so it washes off. Give sticks of carrot to chew after that. So at least it washes off and reduces the sweetness on the teeth.
What about fluoride paste on the teeth? They used to do that earlier. So is that still valid?
Absolutely. Fluoride varnish, it's called. So there were two. One was a topical fluoride, which was a gel that we would put in a tray. And I'm sure I did that for your kids at that time because varnishes were not available in India then. So it's a tray where you put this liquid fluoride, but the varnish is far better. It's like a nail paint. So it actually sticks onto the surface of the tooth. So we use a 5% sodium fluoride varnish that we physically paint onto the surface of the tooth every 6 months. Every 3 months in children who are very high risk. But none of this is vaccination against decay. This is all secondary protection apart from what you're doing at home. And this we keep telling parents, not to have a false sense of security.
Can citrus fruits be given if children are having caries?
Yes, absolutely. I mean, citrus juices is different from citrus fruits. At the same time, I'd rather they squeeze a fresh musambi or orange juice and give it to them, not Glucon-D and Nimbu Pani where they've put a lot of sugar. So there's a big difference in the two. Instead, squeeze the lime into dal, squeeze the lime into salad and give lots of lime because it's so healthy. But don't, so a juice is fine if it's fresh juice. Citrus fruits are great. All fruits are great. They are a great snack. So fruits are a great snack. Nuts are a great snack. Then, of course, your any hot snack is obviously a great snack. But we need to cultivate it also. we culturally, even our bhajis and our vegetables, we do cook them a lot, right? And we kill a lot of nutrients just in the process of cooking. So if they can introduce crunchy salads early to the child, it's always better. We don't do that culturally.
In our meetings, we always have fruits as snacks because Dr. Hemant Joshi, Archana Joshi believes that that's the best snack to have.
Great.
Yeah. Suryakant, you wanted to ask something. Yeah.
Yeah, see, I think today's lecture was an eye-opener for all of us.
Thank
And
you.
I think what last part was the best, I will say, because we are never given such an importance to tongue tie.
Yes.
I think your lecture should be included in the textbooks also. And I think
So.
because it is very important and pertinent, because we pediatricians miss many times tongue tie because we don't examine, and we never thought that it can be a cause of sleep disorders in adults also. And as Anjali has witnessed, the 3 patients had tongue tie when she has gone for a lecture. So I think all our branch people should also, we should have a repeat of that last part, and we can have a discussion amongst us, because I think few weeks back we had this discussion on our group.
That was after her talk.
Yes, but we
Because-
didn't know many of things. So I think it is an eye opener for all of us that we should have this chapter again. We can have revised in a detailed, if you can take a lecture on tongue tie.
Only
And I
tongue tie.
think the message should go to our IAP also, because no one has taught over the years that what is the importance of treating tongue tie.
Yeah, and doctor, it's always that anterior tie. When you see the tip is tied, and even then there are routinely the parents are told speech is okay, let it be. Speech
Yeah,
is okay,
because
let it
that's
be.
what has happened. We have been always trained, if a child can speak well, child can swallow well, if he's sleeping, then don't bother. And we were giving all this year a wrong advice to the patient. So thank you very much.
The other thing is, thank you. And the other thing is, when it goes on to adulthood, what happens is, because the adult is bruxing continuously, there's TMJ issues. And because of the wrong positioning, what happens is the hyoid bone also raises up, it gets stretched. So there's neck muscle pain, postural issues, neck ache, shoulder ache, posture, TMJ issues. So the whole thing is tied to posture, to sleep, to obstructive sleep apnea, to all of it. Because tongue position is not suctioned against the palate. That is the bottom line. That's just the 3 things we need to know. Lips together, breathe through the nose, and tongue up on the roof.
Thank you very much, I think.
Thank you very much. Yeah.
I wish I was a small kid, so I would have got examined by you.
Well said, well said, well said.
You can take your grandson. Yeah, Hemant wanted to say something.
Yeah.
Actually, that is the greatest compliment, that a doctor colleague wants to be examined by you.
Yes, absolutely.
Yeah, well done, Meenakshi.
Well done.
Thank you so much from you.
Thank you so much.
Hemant, तुम्हाला काय बोलायचं होतं?
We were all spellbound and tongue-tied.
Thank you. As long as the tongue was up on the roof, it's okay.
and we were blind, you opened our eyes. Thank you.
Super. Yeah.
I'm so happy तुम्ही एवढा छान मराठी आणि हिंदी बोलल्या, जे काय बोलल्या.
Thank you.
You know it, but you do not know you know it.
पण हे सगळं मराठीमध्ये म्हणजे
केल्याने येते
मला खूप कठीण झालं असतं.
नंद्री केल्याने येईल. ट्राय इट वन्स. ओके. आता मी तुम्हाला काहीतरी सांगणार आहे. आपण 14 लोक आहे, 14 लोकांना चांगले दातवाले 16 पैकी किती आहे? 100 रुपये दे. सो इट्स नॉट जस्ट किड्स. 100% लोक. राष्ट्रीय ट्रेजेडी आहे. Largest India's problem is not pediatrics, it is bad teeth. It's India's largest problem, and we miss it. So thank you, madam, opening our eyes. Right? How bad? Every second child below 5 years has caries teeth, and 9 out of 10 have it at by 12 years. And Pubha Bhave was a great Marathi author. During pre-independence, peri-independence day, around independence. तर त्यांनी सांगितलं की हे इंग्रजांना आश्चर्य वाटायचं की ते दात घासायचे 2-2 वेळा आणि त्यांचे सगळ्यांचे दात किडलेले होते. इंग्रजांना आश्चर्य वाटायचं की ते सगळ्यांचे दात किडलेले होते आणि ते रोज 2 दात घासायचे. आणि आम्ही मिठाने दात घासायचो, राखेने दात घासायचो आणि भारतीयांचे दात चांगले होते. सो आम्ही चांगले होतो. साखर आली आणि आमचं वाटोळं झालं. So sakhar is bad than alcohol, cigarette put together. Number 1 killer of India is sakhar because ते दात किडवते. सो आम्हाला निवडायचं आहे साखर किंवा दात आणि जिंदगी. फक्त आम्हाला हे कळत नाही. इफ समबडी किल्स 1 person यू हँग हिम. सो यू डोंट से की मधून मधून दारू प्या, यू से नो दारू. तर आम्हाला हे केलं पाहिजे की आमच्या घरी नो साखर आणि नो क्वेश्चन. फक्त आम्हाला गट्स पाहिजे, हिंमत करून बोलायला. मधून मधून चालेल वगैरे हे आपण ठीक आहे आतापर्यंत, पण आता आपल्याला बदलायला पाहिजे. आता मी राक्षसची गोष्ट सांगणार आहे. त्याचं नावाचं साखर राक्षस. त्याला काही खायला नाही मिळायचं म्हणून त्यांनी एक दुकान काढलं आणि तो साखर गोळ्या चॉकलेट विकायचा. मग लोक साखर गोळ्या चॉकलेट खायचे, मग दात किडायचे, मग ते मरायचे, दात उपस्थित मरायचे आणि मग ते राक्षस त्यांना खायचा. मग हे खाता खाता तो पण साखर गोळ्या खायला लागला आणि तो पण मेला. सो वी नीड टू, हा अदृश्य राक्षस आहे कलियुग. म्हणजे खरं हे साखर युग म्हणजे कलियुग आहे. आपण या कलीला मारलं पाहिजे, आपल्यापासून सुरू केले पाहिजे. आपले घर साखर मुक्त करा आणि मग आपण दुसऱ्यांना सांगू शकतो. गांधीजी म्हणा ना, मी 1 week साखर नाही खाल्ली मग सांगितलं. सो आय थिंक वी शुड बिगिन फ्रॉम अस. आणि आपण सगळे ते फ्लोराईड व्हार्निश आपल्याकडे येणाऱ्या मुलांना जसं आपण आपले 14 लोक सुरू करूया. मॅडम हेल्प अस ऑन दिस. आपल्याकडे येणाऱ्या मुलाला क्वार्टरली तो वॅक्सिनेशनला आले की त्याला फ्लोराईड व्हार्निश लावून द्यायचा ना. आपण 14 लोक, बी अवर टीम लीडर मीनाक्षी मॅम. आपण 14 लोक करूया.
आय वुड इवन बिफोर दॅट, कारण त्यांना काय वाटेल तिकडे जाऊन आता वार्निश लावलं म्हणजे आर टीथ आर सेफ.
नाही नाही नाही,
द फर्स्ट थिंग इज की
वी विल टॉक टू देम, वी विल डू एव्हरीथिंग.
ब्रशिंग आणि साखर
which we will do. We will do sugar free pediatrician's house and clinic. आम्ही चॉकलेट देतो.
हो खरंच, that is one thing I don't comment on, but
You should na.
Always this big jar of chocolates, and I just think you can with the same, you know, you get. It
So
could be
you should-
we get चणे शेंगदाणे.
आणि तुम्ही कमिशन द्यायला पाहिजे त्यांना. बरं असू दे.
I just feel so sad. It can be so many other things.
No,
Sticker,
we can do it.
some small.
मला 2-3 गोष्टी सांगायच्या आपल्या सगळ्यांसाठी की आपण हे करू शकतो. आपण आपले घर शुगर फ्री करूया. The sky doesn't fall. When there was no sugar, we survived 1 crore years. Number 1. Number 2, आपण fluoride varnishing चालू करूया. What's the brand name for that 5% fluoride varnish? Or whatever.
There are quite a few of them, but they are not available over the counter. These are all.
तुमच्या एक सप्लायरला अंजलीकडे देऊन टाका, आमच्याकडे सगळ्या 14 लोकांकडे देईल. आम्ही स्लो स्टार्टर्स आहेत, 1.5 of us will begin.
But the teeth, yeah, but the teeth need to be isolated आणि प्रत्येक क्वाड्रंटला ड्राय करून मग अप्लाय करायला लागतं. So it cannot be done on wet saliva soaking teeth. म्हणजे कॉटन रोल्सनी ड्राय करून then it has to be white.
ओके, याचं ट्रेनिंग मी तुम्हाला सगळ्यांना देईल. तुमचा एक स्टाफ मला द्या, मी तुमचं ट्रेनिंग घेईन.
I think we should, Hemant, we should start with just training them to brush well and avoid sugar. Then next year we'll start with varnish.
रोज 70,000 मुलं जन्माला येतात. तुम्ही चालू करेपर्यंत रोज 70,000 मरणार. सो वी कॅन्ट वेट.
चालेल, ओके, डन.
ऐक ना, एक अर्धा मिनिट मी अजून बोलणार आहे. सो आपण आपले 14 घरं शुगर फ्री करूया. नंबर 2, आपण 5% फ्लोराईड व्हार्निश. मी तुम्हाला ट्रेनिंग देईल इफ शी डझंट हॅव टाइम, और इफ शी विल डू इट आय एम शुअर. पण इफ शी डझंट देन आय विल डू दॅट. आणि आपण हे करूया आणि आपल्या लोकांना सांगूया की साखर नाही तरच मुलगा जगेल, नाही तर मुलगा नसेल काय, आणि तुम्ही पण नसाल त्याला बघायला. कारण दात किडल्यावर उपाशी मरूनच जातो माणूस. माझं कोण ऐकत नाही, तुम्ही ऐकल्याबद्दल थँक्यू.
Meenakshi, I had one question. Is flossing necessary for children?
Yes. Floss. So the issue is that brushing only doesn't happen, so then we don't burden them with one more instruction. But flossing removes the plaque from the proximal areas of teeth, and brush cannot do that. So ideally, you're supposed to floss first, at least floss once a day. So floss and then brush, so that the plaque comes out from the proximal areas, and then you brush it out.
Okay. Second thing, is mouthwash important for children?
Not really. If you do this much, it's more than enough.
So brushing well and flossing. And I wanted to ask you, there are these teething nets that are available. You know, you can put the fruit in that net and then they can chew. Is that a good idea?
Yeah.
Okay.
Nice. So you feel so that they don't like choke or they don't.
Yes. So it's
Very
now
nice.
commercially available. So
Great.
just
No,
wanted
I
to know.
should actually add that to my. I should add that tip to my lecture. In fact, thanks for telling. Yeah, that is great. In fact, then that worry of the child choking is not there.
Yeah, and a lot of dentists, the old timers, still think extraction is the way out for caries teeth. But I think when you do an extraction, then a spacer is something that has to be,
Again, it depends on the timing of the extraction and which tooth is getting extracted. If it is the last tooth, or if it is the tooth which has one posterior abutment, then space loss will occur. If there are multiple teeth posterior to the extraction site, then space loss may not occur. So there are a lot of technicalities. So it doesn't mean every tooth needs it.
Needs a spacer.
And every age needs it, because on the X-ray, if you see on the radiograph, the new one is coming. Why burden the parent with an additional procedure? So it just depends.
Yeah, Hemant Joshi sir.
मला काय सांगायचंय की आम्हाला कसं जेवायचं हे माहिती नाहीये. तर ग्लोबल गाईडलाईन इज की अर्धा घास कच्चा पाहिजे भाजी कोशिंबीरचा, तर तो नैसर्गिक ब्रश होईल. नंबर 1. नंबर 2, गळ्यामध्ये 6 महिन्याच्या बाळापासून गळ्यामध्ये गाजर बांधून ठेवलं, गाजर, बीट, मुळा, व्हॉट एव्हर रफ व्हेजिटेबल सोर्स, तर ते मुलं चावतील सुद्धा. आणि यू डोंट नीड एनी मार्केट जंक सिलिकॉन. त्यांनी पोट नाही भरत सिलिकॉनने, यांनी पोट पण भरेल. That's it. Thank you.
Yeah. Meenakshi, there was one more question about teeth whiteners. Are they safe and are they recommended?
Not for children, for sure.
Okay.
Bleaching is not good for children. In older population, I mean, even 16 plus, those who really have very yellow teeth, meaning the tooth color is naturally yellow, you can get them bleached. Bleaching, it just causes more sensitivity. So it just depends on the kind of teeth, and then it will lose color and come closer to the original. So you will need re-bleaching every couple of years. But there are people who do it. There's nothing wrong with it. It can be done.
Okay, but not less than 16 years, at least.
No. Because the pulp is young, the tooth is young, and it causes too much sensitivity. And it's not important. I mean,
yes,
aesthetically.
Yeah. Teeth grinding at night. So I think this is the absolutely last question. Teeth grinding, bruxism.
Bruxism, the first thing you need to check is the airway. Bruxism, airway, and tongue tie. Because bruxism is one of the first signs of an obstructed airway. Almost 90% of times, bruxism is because of an obstructed airway. Rarely is it because of stress. And I don't know, they say parasitic worm infections, but then you deworm the child, he's still bruxing. So there isn't that much evidence for it. But the main evidence, and it's all out there, and I just told you also about it, because what happens is when the child or the adult is struggling to breathe, when they're sleeping and the airway is obstructed, one is they drop the mandible and brux so that the airway opens up a bit. And it's also a trigger. It's an oxygen saving mechanism, like I read out there to you. So again, bruxing is one form of the body not letting you go into deep sleep and staying in light sleep because you're oxygen deprived. So the moment you start them on steroidal nasal sprays, the parent will tell you the bruxing has stopped immediately. It has such an impact. Unless the adenotonsillar inflammation is so much that the airway is really compromised.
So we don't have to address the tongue tie at that stage. We have to just deal with the...
So some of them may not have a very bad obstructed airway, but it's the tongue that's falling behind and obstructing in sleep. Because of the tongue tie, the tongue is falling back and obstructing the airway. In which case, the tongue tie release is what will do the trick.
Okay. Yeah. Last question, Dr. Hemant.
No. Decades ago, we sent 3 nurses for a one-day training on fluoride application, and we were overworked all the time, so we never executed it. But you have inspired us to
do it again.
Thank you.
Yeah. Abroad, of course, their dental nurses do it all the time.
Yeah.
It's all over the West and in down under, Australia, New Zealand. It's all dental nurses who do applications at the pediatricians. So what Dr. Joshi is saying is not so, I mean, it's
difficult.
In India, it's unheard of, but around the world.
UNICEF WHO recommended for all children all over, and we don't read them. We don't read those notes.
And also, Meenakshi, someone was discussing that it is possible to do a tongue tie release by nurses in the OPD. Is that so? Is there
So
any?
what they do is a frenotomy. They don't do a frenectomy. So what they do is, when it's a very thin, transparent membrane, they will just clip it. But then that doesn't release the whole fascia. You need that diamond-shaped wound for the tongue to elevate.
Completely elevate.
So you are just removing the anterior tie, and every tie has a posterior component, whether or not there's an anterior component. So the fascia has to be released.
So what is the earliest age you have done a laser for a tongue tie?
So abroad, it is done in the first month.
I see.
But it is not the first step. The first step is the IBCLC or the lactation consultant setting up the posture, making sure everything is good, and training them with the exercises. And then you release the tie so that the mother and the dyad is all set to carry out the therapy the moment it is released. But I have the youngest I have done is at 3 months, because they've not been referred. Because the thing is, we don't have access, right? It's just the awareness. Yeah. You're mute.
Yes.
I have a question. How to give oral midazolam? 5% you said. How do you use that? You add it to paracetamol syrup?
We break the ampule and we mix it in paracetamol or ibugesic, whatever the child is comfortable taking at home.
Right.
The parent gets their medicine. We mix the two because it's very bitter, very bitter.
Right.
But if you mix it in a juice,
Yeah.
it's supposed to reduce the potency. A citric juice will reduce the potency of the midazolam. So you're not supposed to mix it in juices.
Right.
That is why we mix it in ibuprofen or this thing, and give it to the mother only, and the mother feeds the child in the waiting room the way she would feed at home, the mother or the father. The way they would give the medicine at home, they give it, and in about 10-12 minutes, the child is playing, and then they get a little drunk, meaning they're smiling, they feel a little happy, and they are, that's it. But some of them will howl through the treatment. Some of them will smile and get it done like the video I showed you. But some will be crying through the treatment. But they never, so supposing it's just one tooth I have to extract and one tiny filling. I don't want to go into the OT and give general anesthesia for that. So this is ideal. So even if they've cried and we have restrained the child and done the treatment, the moment the treatment is over, they're again smiling, they sit outside, they play, we keep them there for half hour, then they have water, and then slowly oral feeds will start, no force feeding. But there's it's anterograde amnesia. So you don't really remember that unpleasant thing. Happily, they'll say bye-bye to you, they'll take their stickers, and they go home happy. So that's the advantage. You are avoiding general anesthesia. It's a headache for us. It's really stressful, but for them, it's good.
It works 10 minutes?
I'm sorry?
It works for 10 minutes? What is the onset
Oh,
time?
yeah. So the onset of action is about 15 minutes. May you see the onset of action. And the peak is another 20 minutes. And then it starts waning slowly. Okay. So you got to finish giving the LA, the injection, the main work, fat. You have to work very fast. And you have to work like an army is required. All of us working, each one knowing what to do, because you can't waste time. It starts wearing off also very quick. Pedicloral was used earlier, but pedicloral is pretty useless. It's not going to help. So
we can do this for lumbar puncture and things like that.
Yeah.
If you one comment. Meenakshi, if I join you, we can reach this to 36,000 pediatricians. Whatever your core ideas are, I can do that.
Sure.
I think.
Sounds great. I appreciate it.
Yeah, Vaibhavi, I think we are done. And thank you so much, Meenakshi. It's been really an eye-opener, and we really were tongue-tied until the last.
Thank you.
Yeah, thanks a lot.
Madam, for such a
The
wonderful.
only person we did not see is Mr. Khare. We have seen your own family.
Mr. Kher.
Oh,
Kher.
Kher. Sir, it's Kher.
Yes.
Like BG Kher.
Okay.
Yeah. Okay.
Thank you. Bye-bye.
We won't be having a meeting on next Wednesday. We'll meet after that on the next Wednesday.
Thank you, Meenakshi.
Thank you, Meenakshi. Thank you so much.